All right, good morning, everybody. My name is Brooke Phillips. I'm the marketing manager for Shield Healthcare, and welcome to today's webinar on reducing the stigma, the social and emotional challenges of living with incontinence. I'm really excited about today's topic. We talk about incontinence quite a bit, but one of the aspects of incontinence that isn't often discussed is the stigma that's associated with it, and how this stigma affects when and how we seek diagnosis and treatment, what we tell our friends and our family, whether we leave the home, and the many ways it affects our social life, and also how it affects the decisions surrounding keeping loved ones in the home. So before we begin, just a few housekeeping items. Attendees will be in listen-only mode. If you have a question, please type it in the question box on the right-hand side of your screen. There's also a PDF of the presentation slides that you can download. And if you're watching this presentation as part of a group, there are a few forms your group will need to qualify for CE credit as well. At the end of the webinar, we'll go over what you can expect regarding CE credit for this presentation and all of the questions. Your presenter today is Kelly Sparks, RN, BSN, CWOCN with Capital Nursing Education. Kelly earned her BSN from California State Dominguez Hills and is a graduate of MD Anderson's ET program. Kelly is also recently retired from Mercy Folsom. She's also served as a previous membership coordinator of the Pacific Coast region of the WOCN Nursing Society and a working member of the Foot Certification Study Project of the WOCN Certification Board. At this time, I'd like to pass the presentation over to Kelly. Kelly, it's all yours.
Hi, welcome everybody. This is going to be a very interesting topic to me. We have worked on the incontinence topics before, and we've not touched on this. So first I want to look at these objectives with you and kind of go over them a little bit. We're going to discuss how stigma relates to the incontinent patient. We haven't really covered that too much. We're going to discuss the prevalence just real quickly and briefly review the types of incontinence. We're going to look at the types of stigma associated with incontinent patients. And we're going to get very in-depth with the psychosocial effects of incontinence on patients and explore the changes in their quality of life, which is huge, with people with incontinence. We're going to also look at how we can decrease the stigma related to incontinence with these patients. So first of all, let's look at what is stigma. A mark of disgrace associated with a particular circumstance, quality, or person. And there is a good example there about having gone to prison. With people who are incontinent, there is a stigma that they'll always have an odor, that they will get your furniture wet, that they will leave their wet pads everywhere, and that they are dirty people. That's a horrible stigma. So people have the attitude that these people are unhappy, uneasy, and that they have to be more or less homebound. We're going to discuss these in detail, so we'll go over each one of those. So stigmatization, this is a real problem with some people. It's a social phenomenon where there's two groups of people that exist. The insiders who have the stigmatizing trait and the outsiders that don't have the stigmatizing trait. In social settings, the outsiders may recognize that another individual possesses the characteristics that sets them apart and potentially prompting the devaluation of the insider. So stigma is fundamentally a threat to one's self-identity. When you look at it that way and you think about incontinent patients, it makes a lot of sense. The individuals who are stigmatized when they are stigmatized when they possess or are thought to possess an attribute or characteristic that conveys a social identity that is devaluing to them, like I said before. So with incontinent patients, it's huge. They have a really hard time with what people have seen and heard. The prevalence of incontinence, we're just going to go over really quickly. About 17% of women over 18 years of age have overactive bladder problems. And an estimated 12 million adults have urge incontinence. So 1 in 5 adults over 40 are affected by overactive bladder or recurring symptoms of urgency and frequency. It seems very low age, but that's exactly what it is. So overactive bladder and urinary incontinence occur about twice as frequently in women as in men, and it also becomes more prevalent with age. So there's an estimated 17 million adults in the United States that have daily urinary incontinence, and a further 33 million suffer from the overlapping condition called OAB, or overactive bladder. When you look at women between 20 and 45, this is 36.8% that have overactive bladder. And the stress urinary incontinence, the most prevalent form of incontinence among young women, among women in general, affects an estimated 15 million adult women in the United States. Think about that number, 15 million. 29% of individuals ages 60 to 70 experience leakage when coughing, sneezing, or laughing, compared to 17% of men and women ages 30 to 39. So, and a portion of these individuals also experience the urge incontinence as well. Approximately 1 out of every 3 women over the age of 45 and 1 out of every 2 women over the age of 65 have stress urinary incontinence. So when you look at a crowd of people, you can pretty much pick that 1 out of every 2 over 65 in that group are wearing some type of product for their stress urinary incontinence. It's quite interesting when you think of that and look at a crowd of people. It really makes a difference. 1 in 3 over the age of 45, that's a lot. 1 in 2 over 65. So fecal incontinence, a little bit different, but the estimated prevalence of fecal incontinence of non-institutionalized adults is 8.3%. Now, one of the things about this is that fecal incontinence, a lot of times people don't tell anybody about it. So really these numbers are probably a lot larger. Liquid stool, 6.2, solid stool, 1.6, and then mucus is 3.1. So at least weekly it occurs in 2.7% of people. It's similar in men and women, and it's not significantly associated with any race, ethnicity, education, etc. Independent risk factors in women, of course, advancing age, loose or watery stools, more than 21 stools per week, and multiple chronic illnesses and urinary incontinence. Independent risk factors in men is going to, again, include the loose or watery stools, poor self-rated health, and urinary incontinence. It's a big problem with a lot of people, fecal incontinence is. And like I said, these numbers are low, I'm sure, because nobody knows. A lot of people will not say whether they're fecally incontinent or not. They just stay home. Excuse me. So looking at the types of urinary incontinence, stress, urge, mixed, functional, overflow, overactive bladder, or total incontinence. And we've gone over these before in other lectures, so I'm not going to hit on those real hard. But I just want you to see, again, how many different types of urinary incontinence there is. And a lot of people will have multiple. Some will only have one type. Some have a mix. So it's very, very interesting when you look at each one. And we're not going to go through that today, but if you get a chance, go through and read what each one of these does. So then persistent incontinence, this is where perhaps somebody has pelvic prolapse or nervous system impairment, mental or psychological changes. These are things that continue on. Sphincteric weakness following prostate surgery in men or vaginal surgery in women, bladder cancer, nerve and muscle damage, etc. So I want to just touch on one of the things about persistent incontinence that means a lot to me. And fortunately, and it mentions here the surgery, prostate surgery. I want to just touch on that for a minute because there are ways to help that. But one of the things that happened to us is my husband had prostate cancer at age 40. Actually, I think it was 41 before he had his surgery. we had a continence clinic. So before he went to have his surgery, we did biofeedback, we did pelvic floor muscle exercises, we did all kinds of stuff to help prevent him from having the sphincteric weakness after his surgery. And we also trained a lot of other men. We had a pre-prostatectomy clinic that we did in Reading. It worked. I mean, it worked very, very well. And his muscles stayed nice and strong. He had a radical prostatectomy, and it was quite evident that the work we did really, really helped. And he continues to do the exercises and different methods to keep from leaking after that surgery. So I just wanted to put that in there, that with the prostate surgery in men, if a person has cancer and they know they're going to get it even before, I think they should start doing, men should be doing Kegel exercises just like women should, just in case. And, you know, the other thing I want to say is my husband was only 40 when he was diagnosed. I have children that are 40. And yes, I'm old. But the thing is, if you have loved ones, children, whatever, I urge you to have them checked. I mean, my husband had no symptoms whatsoever, none. We just happened to be at a like a health spree, and there were different places you could go to be checked for your blood sugar, your this, your that, and one of them was a prostate exam. And so I encouraged him to do that. This was before we were married, and lo and behold, they found that he had prostate cancer. So even if there are no symptoms, please, please, please urge your loved ones to get checked. It really paid off for him. He's still alive. And they said that it was 1 millimeter from exiting the capsule. So he would have been dead within a month. And so because I saved his life, I had to marry him. Okay, sorry about that. I had to get it in there. So let's look at the transient causes and the acute incontinence. Transient causes, you can see the extra P in the diapers. That's an old acronym that we've all used, but those are the transient causes. They're going to be there, and then they can go away. Stool impaction, for instance. Disimpact, fine. It may help, and they may not be incontinent anymore. I've seen young kids that in my practice before that were incontinent and fecal incontinence and urinary incontinence, and the main reason is they had megacolon and they had stool impaction. So you teach them how to defecate correctly using biofeedback, and lo and behold, they're not incontinent anymore. Acute incontinence can be from, again, the stool impaction, but also psychological factors. I had some kids that I treated that would not go near a toilet. Don't know why, but they ended up with megacolon and ended up having incontinence as well. Again, medication side effects or inflammatory processes in the urinary tract can also be acute causes of incontinence, and these can be treated. They can be treated and taken care of rather quickly. In women, stress incontinence, leakage from sneezing, exercising, coughing, whatever, and also that can happen with men, by the way. The side effects of medication, certain foods, weakened pelvic floor muscles, these are all the causes of urinary incontinence in women. They say aging here, however, I firmly believe that aging does not make you incontinent. Severe constipation again, and changes in their body from childbirth or surgery can be the different causes for women. In men, it's most often the effect of surgery. Prostate cancer or BPH, it can be a symptom of diabetes, stroke, MS, anything like that. So those are some of the causes for incontinence in men. Sometimes it can develop for less clear reasons, such as an overactive bladder, which can also be treated. Fecal incontinence is huge. That is such a problem for some people, and you can't even imagine. It's horrible. The stigma around it is just really, really intense. there's a list, this is a list of medical conditions that can cause bowel incontinence. And that, of course, includes forceps delivery for women. Sometimes they really injure those muscles and the sphincter doesn't work anymore. Peripheral neuropathy for diabetics, reduced anal sensation. And you know, there's nerves in there that tell you whether this is solid, whether this is air, whether this is liquid that's sitting right at the anal verge. And when that doesn't work, you have no clue what's going to be coming out of there. So a lot of people have that kind of problem as well. Now, getting back to stigma, there's three types. One is the perceived stigma, okay? And that's when there's fear and worry about being subjected to a stigmatizing event. Then there's self-stigma, directing, okay, this is when somebody has their own attitude of, oh my gosh, I'm bad, I'm horrible, I'm incontinent, therefore nobody likes me. That's the self-stigma. Enacted stigma, episodes of discrimination based on a stigmatizing attribute. These things are the three types that I could find of stigma, and it's very interesting when you read about it. I had not done that until this lecture, so it was very interesting. In all the years that I've been doing different talks, different lectures, everything on incontinence, I don't think I ever said the word stigma. And I feel really stupid now that I didn't come up with that. So I'm having a self-stigma, I guess, about it. All right, so, you know, we're socialized to understand that elimination of body waste is a private matter, and it should be done in a tidy way. Failure to do so risks being stigmatized. So examples of this I could tell you is, you know, in a restaurant, sitting there with my grandchildren, and my little grandson says, Mama, I have to poo. And the lady behind us turned around really quickly and looked at us and gave me the dirtiest look. I'm like, wait a minute, this is a kid, and he's, you know, he was 4 at the time. And they don't know yet. They don't know yet this socialized understanding that we're not supposed to talk about it, we're not supposed to say anything about it in public, and it was really, really, that look was intense. Another example is being in a restroom. Now, being from a urological education, I guess I'd say, when I go into a restroom, let's say I go in and I'm in the stall and I hear everything because I'm used to listening. How is that uroflow? You know, does that patient have hesitation? Do they have, you know, because we do that in a urology clinic. We listen to people urinate. So to me, I could sit there and listen all day and diagnose everybody that walks in. But those are just examples of it. And people who have ostomies, I can tell when somebody has an ostomy now when they go in and empty in the bathroom. So it's just interesting how we're not supposed to talk about it. It's a private matter. It's just, I know we've been socialized to think that way. And sometimes it's really sad because you need to talk about it when you have a problem. So incontinent patients, they are perceived as being different. They're stereotyped as frail, independent, dependent on other people, incompetent or old. It threatens their adult status, and they can be embarrassed, shamed. There's a lot of stigmatization around frequency, urgency, and nocturia. When you think of somebody, well, I can go back to when I was a kid. I could not spend the night with somebody because I wet the bed. I wet the bed for a long time, and nobody knew why. I was never checked out by a urologist or anything. They just figured, she just wets the bed. But it was horrible because I couldn't do normal things that other kids did. My mother just was so wonderful about it that she did not make a big deal out of it. They taught me how to go put my sheets in the washer and how to put them back on the bed before my sister got home because she teased me all the time. And so they dealt with it in a very gentle way, that didn't make me feel too bad, but definitely I couldn't do the things that other kids did. So it was socially disruptive because I couldn't participate in a lot of things. So it was pretty difficult. And the stigma around that, yes, that happened too. My sister did tell all of my friends and everybody at school that I wet the bed, and that was horrible. But really, my friends didn't have a big deal about it. Just, some people did. It was pretty hard as a kid. The Six Stigma Dimensions here, it's so interesting how there's different dimensions that go along with the distinguishing characteristics. So, is the trait apparent to others? That's one of the questions that really, really bothers people that have incontinence. Does the trait become more prominent over time? That's the course of the mark. Disruptiveness. Does the trait impede social interactions? Of course it does. There's a lot of times that it does. Aesthetic. Is it unattractive to others? Well, if they could see, it would be. Origin. Is the trait individual perceived to be responsible in acquiring or creating the trait? Usually not. And then peril. Is the trait perceived to be dangerous to others in social settings? No, it's normally not. Now, there are some cases, and I just have to say, I've taken care of some HIV patients that literally would throw stool at you. And unfortunately, their brain was deteriorating. So there is that is a danger to other people. Not to mention, one time I was putting a condom cap on a paraplegic, and he wanted to help, of course, and I should have just let him do it, which I kind of did. He got his hands in there, and he snapped the end of the condom cap, and it splattered urine into my eye. And I wore contact lenses at the time, so it was not very good. I ended up having to, we both had to be HIV tested, all of those things that happen in the hospital when you get splattered with urine. So yes, it can be a little dangerous at times. So there are questionnaires concerning stigmatization. There was a study done, and the goal was to evaluate the efficacy of any available questionnaires. One of the, this is Southall that did this study, and the literature search showed 194 references. 11 questionnaires fit the inclusion criteria, so not very many. 6 out of the 11 didn't even have any stigma content. So really, there's not a lot of information about it. The remaining 5 had very limited content regarding stigma. So obviously, further studies need to be done to examine how the stigma associated with continence difficulties impacts upon healthcare interventions. So that's for those of you out there who are looking for a study to do, possibly for PGP points for WOCN or anything else, do a study on stigmatization of incontinent patients. It would be a great study. Okay, the most interesting part about incontinent patients to me is the psychosocial issues. There is a lot of things having to do with the psychosocial issues. Because of the stigma of incontinence, there's sometimes issues with these patients that are incredibly complex. The psychosocial evaluation of the individual with incontinence begins with the healthcare professional attempting to gain an understanding of incontinence as perceived by the patient through the patient's experiences and the concept of the meaning. So after gaining this understanding, and only then can they engage in a care plan designed to help this patient. So it's important to know exactly how the patient is dealing with each of these concepts. There are some people that have no problem with being incontinent. Some people just wear pads and they're fine. Other people have all these difficulties that you see here on this slide. Many patients don't even tell anybody about their incontinence because of the stigma. And they feel helpless and afraid, just like it says here. And if you look at each one of these things, you can see that everything here is associated with this patient with incontinence. There are people who choose not to leave their homes, can't go anywhere because of fear of leakage. There are people who won't discuss it with anybody. They won't even talk to their doctor about it. And if they do, you know what the doctor a lot of times will say is, let me know if it gets worse. How helpful is that? Let me know if your leakage gets worse, and then we'll take care of it, or we'll investigate, or whatever. So they also are afraid to be nice to anybody. So they usually isolate and don't communicate well. And God forbid, if you're nice to somebody, they might invite you to their home. Then what do? You know, you might leak on their couch. You might sit down to play cards or something and laugh too much and leak on their chair. Worse yet, someone might smell urine. And how does that make you feel if somebody next to you says, wow, I really smell some urine in here? You know, these things make people stay home. Another thing, too, what if you have to change your pad? Think about it. Put yourself, you know, empathy is the biggest, you have to have empathy for these people in order to understand what's going on. Where are you going to put a wet pad? You're going to leave it in the bathroom? Somebody's going to walk in there and smell urine? Are you going to, you know, what are you going to do with this? What I've done with my patients is I always told my patients, you take a Ziploc bag in your purse, you take your wet pad off, you put it in your Ziploc bag, and you put it back in your purse. It sounds terrible, but I'll tell you what, it's a lot more comforting to do that than to have the family dog drag it out of the bathroom. I mean, that has happened to people. In our, I'll tell you more about the support group, but in our support group, I heard so many things like that were just, it was just horrible. And so when you look at this, helpless and afraid, that's it. Everything on here, loss of dignity, lonely, they get very lonely because they don't want to go anywhere. Is the pad noticeable? Can people see it when you're walking? All of these feelings up here apply to these people, don't they? And what about the barriers to seeking treatment? There's a lot of barriers to seeking treatment. Simon Foundation, in their guide for promoting continence, had a list of myths. And one of them is, I'm just getting older, therefore I'm going to leak. That's a myth. The other one is, like I said, my doctor said, let me know if it gets worse. That is such a horrible thing to say to a patient. I just want to talk about when I was getting old, when I was younger. Like I said, my sister told everybody that I wet the bed. I had stress incontinence if we were, you know, doing something and I ended up laughing too hard. I may leak. I didn't wear any products. I didn't need to wear anything. I probably should have, looking back. But this one time, I have to tell you, it was just really, really sad. We were at my friend's house, and we were all playing that game called Twister. And that's where, you know, you spin the dial and you put one foot on this, you know, color on the floor on this pad, one foot on this one, and you spin again and you put your arms. And I actually was straddling over my sister. Well, they made me laugh. So unfortunately, I leaked all over my sister. And she got mad and yelled at me, and I jumped up and I went running up the alley, and I was crying so hard. I was so embarrassed. I was humiliated. It was horrible. But halfway up that alley, my tears just turned to laughter, and I was laughing so hard. And I kept thinking, you know what? Serves you right for telling everybody that I wet the bed. And I laughed so hard because I peed on my sister. And I thought it was the best thing and she deserved it. And it was funny. But, funny thing is, my friends, Lynette and Sylvia, they never said anything about that. Never said anything about that. So that was quite interesting. And it was kind of fun. Okay, the effect on incontinent patients' self-esteem. Nearly 1 out of every 5 men over 60 is dealing with male urinary incontinence. Okay, and most men, they will not tell anybody that they have any problem. They feel very humiliated. They feel like they're an invalid. Men do not deal well with incontinence at all. And fecal incontinence is even worse. Men don't tell anybody. It's usually the wife or girlfriend or boyfriend or whoever that does their laundry who notices. And sometimes, of course, they're afraid to say anything to them, but men just are really, really sensitive about it. And they have a special type of stigma about incontinence. And that is because they're supposed to be men. They're supposed to feel like strong men. And a lot of men with incontinence feel and have told me they feel less of a man. It can really, really affect them sexually as well. They have such dysfunction. It's really, really sad because they are, they just don't want to have sex. Women over 65, they're pretty well used to wearing pads if they wore them when they had their periods as a kid. But nowadays, the girls, at least the ones I've talked to, don't use pads. Some do. But usually they will use tampons. And so nowadays, the younger girls that become incontinent after they have a baby, for instance, they have trouble with wearing pads as well. But men do not like pads. And I'll tell you another thing that happened to me that really, really helped my self-esteem is I can remember one time, yes, we were playing a game. There was, 4 or 5 of us, and we're playing a card game. And I laughed so hard that I wet. Okay, so here I am sitting there wet. And what do you think I did? It was the best thing that I could do. I spilled my water in my lap on purpose. That way, nobody knew that I leaked. So, there are ways that people deal with this. But I got to tell you, men have the most problems dealing with their incontinence because they're not used to that type of thing. So the quality of life is very, very important with these people because it greatly is diminished with urinary incontinence and fecal incontinence. So it's important to diagnose them adequately. You have to be able to diagnose the 3 types of urinary incontinence correctly. There's stress, urge, and mixed. And evaluate the impact of incontinence on the quality of life of this patient. So after a detailed history, the bladder and a bladder diary, questionnaires are the most useful tools to determine what aspects of quality of life are most impaired. So they have found that your urgency and urge incontinence have the worst quality of life than stress incontinence, have the worst effective quality of life. And measures of quality of life have become essential in developing management plans for these people. So most of the quality of life questionnaires that you can get cost between $200 and $500. And studies have been done to show, their effectiveness. But I had one in the continence clinic that started with, in general, would you say your health is excellent, very good, good, fair, or poor. And this gave me an indication of where that patient was with their psychological aspect of their fecal incontinence. If they said their health was excellent, then they don't have a big issue with it. But this helped me to see what they were going through. The second question was to indicate how much of the time the issue is a concern for you due to accidental bowel leakage. And if it is a concern for reasons other than accidental bowel leakage, then they would put NA. And that gave me it allowed me to determine what their concerns are. And by putting NA, then that would lead me to a question to the issue, and possibly it would be due to the stigma. So that NA was very, very important. And if you look at this questionnaire that I used to use for fecal incontinent patients, it addresses everything that I was just talking about. I'm afraid to go out, okay? Is it most of the time, some of the time, a little of the time, none of the time, or NA? Well, I avoid visiting friends. Again, the same thing. Circle the number that it is. I avoid staying overnight away from home. It is difficult for me to get out and to do things like going to a movie or to church. I cut down on how much I eat before I go out. Whenever I'm away from home, I try to stay near a restroom as much as possible. It is important to plan my schedule around my bowel pattern. I avoid traveling. A lot of these people avoid traveling because you have to take a lot of pads and stuff with you. I worry about not being able to get to the toilet on time. I feel I have no control over my bowels. I can't hold my bowel movement long enough to get to the bathroom. I leak stool without even knowing it, which is very common. I try to prevent bowel accidents by staying very near a bathroom. You can see how every one of these things can affect their quality of life. They're not going to go anywhere if they have these problems. I love this questionnaire. I used this with my patients, and it worked very, very well. Most of the time is a number 1, some of the time is a 2, and etc. And the lower their number, the lower their number, the more of a problem it was to their quality of life. So there's another example here. If you were to spend the rest of your life, this is for urinary, if you were to spend the rest of your life with your urinary condition just the way it is right now, how would you feel about that? And over the past month, how much of the time has a urinary problem kept you from doing things that you would usually do? This gave me a great, this is only part of the questionnaire, but this questionnaire gave me a great amount of information on what their life was like, what their quality of life. And I got to tell you, there was a little lady who actually had fecal incontinence. And she came to me, I've told this story before, so you may have heard it, but she came to me in the continence clinic with just the most depressed affect. Her face was just hanging, and she was in her 80s. She was an avid golfer, and she had been golfing, at least 3 times a week, all of her adult life. So she came into the clinic just looking so forlorn, just sad, and scared. She was scared to even come in. And I had to work with her a long time to get her to even talk to me about her problems. So as it turned out, to make a very long story shorter, she came in for quite a while, like 2 months. And we did diaries, we did all kinds of stuff. She made a beautiful calendar. And what I did with her is try to train her bowels. So we started, of course, with exercises, etc. But we also did suppositories. And every day she was to do a suppository, have a bowel movement, and go through this period of time training her bowel. I also put her on Metamucil, which really helped. So what happened is, after all of this, we did the quality of life questionnaire again. It was incredible. We had gotten her bowels to where she could actually golf again. She knew exactly when she was going to have a bowel movement. She knew exactly how to maintain that routine with her food and her suppositories, which, by the way, we got to quit doing after a while. It was incredible. So she did get to go back and play golf, and when she came in at the time that we discharged her from the clinic, when she came in, her face was totally different. Now, we took pictures of our patient's face when they first came in so that, you know, to recognize them, put them in their chart and stuff. And you couldn't even recognize this lady. She was totally different. Her face was so happy, and she just looked so good. So it is a quality of life issue. And her quality of life was horrible before she came in. So I was real thankful for that lady. The impact of quality of life with people with stress, urge, and mixed incontinence. A study was done by Coyne and their group, and they examined the impact of each type of urinary incontinence on health-related quality of life. They had 919 participants, 82.5% were female, and 85.4% were Caucasian. The average age was 55.9 years. Now, the conclusion of this study showed that with stress, respondents with urge incontinence and mixed incontinence reported not only significantly greater ratings of urinary urge intensity and more incontinent episodes, but significantly worse on their health-related quality of life. So it's consistent with previous findings that indicate the greater impact for urge component of mixed incontinence rather than the stress component. I just have to say here with urge, and the reason why urge is worse for people with, as far as their quality of life is concerned, I had another patient who, with urge incontinence, it can be a visual that causes that urgency. It can be a thought that causes that urgency. And this lady came to us, this is before we worked hard to increase her quality of life. She came to us and said that she could not go to the store. Every time she went to the store, she would walk into the store with the fear that she could not completely go through the store, and she would immediately have urge and have to go find the bathroom. She would come out of the bathroom, have that same feeling of, oh my gosh, I'm not going to make it through this store, and she would end up back in the bathroom. And she couldn't get through a department store. She could not shop. The other thing that she had, the problem she had was at, and I won't name it, but, you know, the big stores that sell toilets. She would walk in, her eyes would see a toilet, and she'd have to run to the bathroom. It was so intense that she could not go in those stores because of that. She would leak if she didn't hurry up and get to the bathroom. And it was all because of the urge. And it's mind over bladder. I mean, you have to teach, and we won't get into that, but you have to teach how to control that urge. And for her, she couldn't even go to the movies. She could not sit in a movie for 2 hours without going into the bathroom. And that is one of the questions on one of our questionnaires is, can you sit through a 2-hour movie? She could not. She could not. I have a friend who knows where every single bathroom is in the town that she lives in. And, you know, there's even a bathroom, I think it's a journal or a bathroom book that shows you. You can actually get books that show you where every toilet is in a town. It's incredible. And that's because of urge. She cannot go where she doesn't know where a toilet is. So let's talk about overcoming this stigma. This is the biggest part of this and how difficult it is. Now you know how horrible the stigma can be. Overcoming that. The most basic element of empowerment when it comes to the medical condition is knowledge. Okay? So by educating patients about the realities of urinary incontinence, the situation can be demystified, and they can actually learn that it's not so scary. I think every doctor should know more about incontinence than they do. They need to empower the patients and demystify the situation, explain how the bladder works, explain that it is a common problem, straightforward manner of discussion, not, oh, well, if it gets worse, let me know. You know, that just does not get it. They need to explain the causes, how to fix it, how it works, and what is wrong with it. There's also discreet products nowadays and simple exercises. Urogynecologists are not only for surgery. They can help patients gain control by recommending and teaching exercises that can help. They can educate the patients on the variety of affordable incontinence products that can help. And when surgery is the best option, they need to explain the current technology that's designed to provide outstanding cure rates from simple procedures. There are simple procedures that can help people with incontinence. And by all means, every woman and man, in my opinion, needs to know Kegel exercises. They can be very, very beneficial for people, especially for women. I just urge you to get your doctors on board, your nurses on board with how to do the Kegels. It's so simple, it's so easy, and it just needs to be taught to people. Providing personal, compassionate support is extremely important. You've got to remember to consider the quality of life effects of urinary incontinence rather than just the medical. Some patients, like I said, don't even go to work. They skip work, they skip social events, they experience sexual dysfunction. We need to have empathy for these people. Put yourself in their shoes, or panties, for a period of time and look at what they go through. And they do sometimes need additional support. They might need to have counseling for this, but by all means, they need to go to a continence clinic and get the help that they need. I have an example here of goals of treatment, and one of them is to improve the ability to suppress the urgency and delay voiding, reduce urgency or urinary frequency, increase bladder. This is just an example of what I did as the goals for treatment, and restore confidence in bladder control. That's the main thing, restore that confidence. So again, patient teaching, teach them normal bladder function, what types of incontinence that relate to them, and the normal musculature and the deviations as related to their problem and their condition, exercises that prove effective in re-educating the patient's pelvic floor, dietary issues, suppression techniques, voiding protocols, daily diaries, and of course, we have to always leave time for questions. So what I did was a 2-week exercise program with them with their Kegel and behavior modification, set them up for that, and then they would return and have biofeedback as needed. With behavior modification, you can see some of the things here. I won't go over them because we'll run out of time, but basically, look it up. Behavior modification includes dietary issues, suppression techniques, voiding protocols, daily diaries, and again, mind over bladder. I just can't tell you enough how much that works with urgency. You need to really have the brain-bladder connection there. I am dry. This is Cheryl Akey's from 1996. Imagine you're going to succeed. Aim to restore muscle strength and tone, motivation. Devote time each day for it. Remember, it will take time, and you are the key to success. So motivation is very important, and you have to be very motivated to teach these people. Continence support groups, I have so many stories about the patients that came to our continence support group and told us things that happened that you would not believe. And it was awesome. And everybody there shared their success stories as well. Even if, and I've had people say, I am using one less pad per day. And that is huge for some people. But I need to tell you this. In a survey of 36,000 Americans with incontinence, Jeter and Wagner reported that 17% described their incontinence as a major problem with important social implications, but the rest described it as a relatively minor problem with limited impact on their respective lifestyles. So understand that not everybody has the stigmatization, not everybody has a problem with it. Some people like me get over it. Some people can just live their life normally, and I think that's due to our current commercials. You look at advertisements on TV for pads, for meds, for different things, and the different ways that the urogynecologist or the surgeons can help. So it is becoming less of a stigma over time. I really believe that. So continue on with teaching your patients, and it should help. We have references here for anybody who would like to look at them and look up some of the studies that I referred to. And that's it for me.
Great. Thank you so much, Kelly. What a wonderful presentation. Really appreciated all of that information. Just very quickly, we're going to go through a couple of slides we have here about, for example, getting your CE contact hour. Your CE contact hour will be provided by Capital Nursing Education. You can expect to get it within the next 5 to 7 business days. It will come into the email that you provided when you registered for the webinar. If you registered and are watching in a group, make sure you fill out the group forms so that we have your email and your license information to send that to you. Please check your spam folder if you don't receive it within the next 5 to 7 business days. And if you don't receive it, please reach out to marketing@shieldhealthcare.com and we'll make sure that we can help track that down for you. Kelly, would you mind going to the next slide? Perfect, thank you. We also have a lot of information. We have over 2,000 informative articles on the Shield Healthcare community site, which is our community blog. We have different topics, including incontinence, so you're welcome to join our incontinence community there, read all of our information, watch videos, and we also have other communities as well as the caregivers community, healthcare professionals community, and there's a lot of overlap in the content there. So feel free to take a look there and also to register for any upcoming webinars that look interesting to you at shieldhealthcare.com/webinars. If you don't mind going forward, please, Kelly. Thank you. And then there are also booklets, free booklets and guides you can download. We get free PDFs. If you need a printed copy, feel free to email us and we'll make sure you get that as well. But you can find those guides, including Living Well with Incontinence, with a lot of different tips. Aging safely at home is another one that might be relevant. And you can get those on shieldhealthcare.com/community. And next slide, please, Kelly. Great. And then also, if you are interested in having this webinar presented in your agency, feel free to reach out to us at marketing@shieldhealthcare.com or also to capitalnursingeducation@gmail.com, and we'll make sure that we get this handled for you. And I think that's it, Kelly. If you want to go to the next question, we'll address, the next slide, we'll address all of the questions that have been coming in. So thank you for that. We have quite a few that have come in. I'll just start from the top. What is your opinion for psychosocial issues with regards to Alzheimer's patients? It seems that my mother may be embarrassed, but then she forgets about it.
You know, that's a hard one because do we know that she's really embarrassed or, yes, she's going to forget about it? Alzheimer's patients are a whole different ball of wax, and you know that most of what happens they usually don't remember, but then they'll have moments that they will remember and feel, compelled to feel embarrassed. But that's a hard one. I'm not sure what to do about that other than just try to encourage her that that's what happens. And you can't teach. I have tried teaching, Alzheimer's patients and some with just a little dementia. It's very, very difficult to teach them any pelvic floor muscle exercises, that's for sure. They have to be cognitively able to understand and go through the motions. So it would be difficult to try to teach her.
Great, thank you, Kelly. Another question. Are there exercises or ways to help, besides diapers, for fecal incontinence?
Yes. Actually, Kegel exercises do incorporate the entire pelvic floor. And a lot of times why people become fecally incontinent is due to the fact that they have megacolon. Sometimes that is the only reason. And biofeedback teaches these people not only how to tighten their muscles, but how to relax. because a lot of times people who do not defecate correctly end up with fecal incontinence because of impaction. So it's very important to get to a continence clinic, talk to your GI doc, talk to, your surgeons, whoever. But the main thing is the exercises can help fecal incontinence as soon as they're cleaned out enough to where they're not having any impaction. Start those Kegel exercises and concentrate on the relaxation so that they can relax and not try to have a bowel movement against a closed wall. That's what happens, is they don't open up enough. So yes, exercises are great for that.
Okay, great, thank you. Another question that's just come in: why is urinary urge more prominent at night when you are in bed?
I don't know the scientific part, why, but what I've found with my patients is when they drink, after 6 o'clock. This is why we teach them not to drink after 6 o'clock. Don't drink any water after 6 o'clock. Get all your water in during the day, 8-ounce glasses during the day. After that, after 6 o'clock, try not to have any. The other thing is coffee, anything with caffeine, anything that causes urgency, any acidic drinks, anything like that, you want to just totally knock out and not have it all. But at night when we lay down, we are making urine as we're laying there. You're going to have the dribbling from the ureters into the bladder. It happens. And so once that urine gets in there and touches those nerves, you can get the urge. A lot of people wake up, and they say for people over 70, twice a night is normal. People over 60, once a night is normal. So urgency happens because of that urine going into the bladder and all the different types of things that we put in there, in terms of the caffeine and diet sodas and stuff like that.
Okay. Next question. How do you feel about referring patients to a physical therapist specializing in pelvic floor?
Oh, absolutely. Everything I learned about pelvic floor muscle came from physical therapists. I was the only WOCN in a lot of the classes that I have taken over the years. Most of them are physical therapists. So definitely. And, I think because of the fact that they know muscles, they know these pelvic floor muscles. And we have some local ones that, absolutely just are wonderful. I definitely would say physical therapists do know what they're doing with muscles. And there are WOCNs that have learned this from physical therapists, and they know too. So either one is fine, as long as they have the education behind them.
Great, thank you. We have so many questions coming in. I'm just going to try to get through as many as we can. And the ones we can't get through today, we'll definitely email you. We'll follow up to answer your questions in person. This question came in via email, so I want to make sure it's addressed as well. Does this ever go away, and does the diuretic work?
Does urinary incontinence ever go away?
That's my interpretation. Does urinary incontinence ever go away, and does the diuretic work?
Yes, urinary incontinence can go away. I'm a good example of that. She could email me, I could tell her. But pelvic floor muscle exercises are the main thing for becoming continent. And yes, definitely, it can be treated. It can be treated surgically. It can be treated as an outpatient. It can be treated with injections. There are many, many treatments for urinary incontinence. So yes, it does go away. Diuretics, if you need to get rid of a lot of fluid in your body, that's great. But that really, they cause, a lot of times, diuretics will cause a little bit of incontinence as well. So if patients have to take diuretics, they just really need to beef up those pelvic floor muscles.
Great, thank you. We have so many questions coming in here. Let me see if I can power through a few more with you, Kelly. How do you approach to help a person that chooses to use pull-ups instead of go to the bathroom?
One of the things about urinary incontinence is you can lead a horse to water, but you can't make them drink. if that patient is not interested in getting help, there's nothing you can do. You just buy more of the pads and briefs, because unless they're willing to go through the exercises and go through the questionnaires and go through all of the things that we do for treatment, they're going to be incontinent. And maybe that's a person who it doesn't bother. They don't have any stigma related to it. They don't worry about it. And a lot of people choose to just, you know, in this day and age, we have such good products out there. A lot of people would rather just go and you know, buy those briefs and wear them rather than get help. And like I said, in the last study that was done by Jeter and Wagner, only 17% of the people that they questioned had a problem with it. So some people would rather wear the pads than to deal with the problem.
Great, thank you. And just one last question. How do we find more of your webinars? I'll answer that one. There are several questions we didn't get a chance to get to, but we will make sure that we reach out to you in person to answer your questions. If you are looking for more webinars to attend, you can find them at shieldhealthcare.com/webinars. That will have our upcoming webinar schedule, and usually within the next month or so, we will upload the next 6 months worth of webinars. So please, if you don't see anything past June, check back. We'll keep you posted, and we look forward to seeing you in future webinars. Kelly, thank you so much. I believe that's all we have time for today, but we really appreciated your time and your expertise. And thank you to everyone for giving us part of your day. We appreciated having you today. Thanks so much, and have a great Wednesday.
Thank you.